Hello, hello. If everybody can take their seats for an exciting presentation. Bonjour, sawadee ka. We're about to start. We've lost our first presenter. Okay. It's a real pleasure to have everyone in the room for this session. It's so important, so topical. I don't think I need to convince any of you of that. And this session is going to operate a little bit in English and French. Unfortunately, there's no formal translation, but one presenter will be presenting in French, although his slides are in English. I think we have enough bilingual people in the room that should you wish to ask a question in French at the end, please feel free to do so. Donc, c'est quel plaisir d'avoir tout le monde dans la salle pour cette session si importante et d'actualité. Malheureusement, nous avons legal abortion, global insights, successes, and failures. And it really promises to be just that. We have some fantastic abstracts and presentations for you. As we heard from UNFPA's executive director yesterday, Natalie Canham, and in their groundbreaking report, Seeing the Unseen, nearly half the pregnancies in the world are unintended, amounting to 121 million every year. And very, very, very many of those are among adolescents who face the greatest discrimination. An estimated 60% of unintended pregnancies end in abortion, half of which are unsafe. So this isn't just a public health crisis, it's a human rights crisis and a denial of fundamental rights. But there is hope, as you'll see in some of this research being presented, that despite increasing restrictive legal environments in some influential countries, in quite a few other countries, abortion access, while still limited on specific grounds, is liberalizing in laws, policies, and practice. So in this session, we have two presentations which will look at multi-country lessons, and three which will dig deep into country realities, one from Burkina Faso and two from DRC, for a total of 5. And you'll see from the presentations as well, some of them look at expanding access from the individual perspective of the woman. Some look at the role of organizations in the supply and demand and what were the factors of change. Some have lessons in policy change, and some are looking specifically at the role of healthcare workers, and one is looking at expanding access in the humanitarian context. So we really have a good mix, not just of countries, but also of different scenarios. What we're going to do, I know each presentation will be 10 minutes long because we have 5 presenters, and I know 50 minutes seems like a long time to sit before asking questions, but in the interest of having enough time for discussion and in fairness and equity kind of among the presenters, I'm going to ask people to preserve their questions to the end, because I think there's enough kind of links between the presentations that you'll be able to ask questions that kind of thread across presenters. There's also apparently supposed to be questions from a virtual audience, and I'm supposed to have a tablet here, but I don't. But I'll try and figure that out as well, and somebody who might be more techie-minded than me can shout out a question from the virtual audience. So we're going to kick off with an abstract from Nathalie Kapp, if you can come up. Looking at the findings from a 15-year program to expand access in 23 countries, and really making the call for us to take a long-term view to expanding abortion access. So Nathalie is an obstetrician gynecologist who is the chief medical advisor for IPPF. She's worked as a medical officer in the Department of Reproductive Health and Research at the World Health Organization in Geneva for 7 years, doing very interesting research, and as a senior medical officer at HRA Pharma in Paris. Most recently, she was the medical director at IPAS and the principal investigator of research on safe use of medical abortion in over-the-counter-like settings, expanding the provision of medical abortion after 13 weeks gestation, and reducing barriers. And she's authored more than 65 peer-reviewed publications of her research. So thank you very much, Nathalie. I need to put my shoes back on.
Hello. Thank you so much for the opportunity to talk to you today. Just one moment while I wake up my computer and make sure that you all hear me well. And I'll just add on to something that you said. You know, the vast majority of legal changes that have happened in the space of abortion over the last 20 years have been towards liberalization. So it's really the outliers who are going backwards. So it's my pleasure to present to you today on behalf of my colleague Rebecca Wilkins, who was unable to be here today, our work on Global Comprehensive Abortion Care Initiative, and I'm going to talk globally over this initiative from the past 15 years. And I think most of you know this background, but I'll run through some concepts I think that's good to keep in mind. That access to safe abortion varies greatly depending on geography, legal and social contexts, and health systems capacity. That safe abortion technologies and other interventions are actually quite simple to introduce into primary care settings, but unsafe abortion remains a significant public health concern, which we just heard. Long-term investment in interventions are required to achieve access to safe abortion in the most challenging environments. And that's the setting for which we undertook this program about 15 years ago. The intervention that we designed had two main parts. One was a supply-side intervention, and the other was a demand-side intervention. On the supply-side intervention, we included clinic infrastructure development, procurement of equipment, also of commodities, health worker recruitment, and very importantly, their training and skills building. Built onto this was values clarification and attitude transformation activities, not just for healthcare providers, but also for staff, and developing quality of care frameworks and monitoring. Our demand-side interventions included community education and awareness interventions, referral partnerships from other CSOs, so civil society organizations, also from surrounding healthcare providers in other fields, mobilizing community health workers and peer educators, and in some contexts, mass media communication. Our methods for this presentation and analysis was a mixed method, qualitative and quantitative analysis. The data were reviewed and analyzed with a focus on the aspect of the program seeking to expand access to comprehensive abortion services. And as many, or maybe all of you know, comprehensive abortion services also includes post-abortion contraception and counseling. However, in the data I'm presenting today, I won't be talking about that aspect of the program, but it was included. We looked at service statistics data against key indicators that were collected from 19 of the 23 countries and member associations. 4 of them were not included. If you might remember, this included 23 countries. 4 of them didn't have complete enough data for us to look at them in the analysis I'll be presenting. We also included findings from 16 key informant interviews that were conducted in semi-structured interview formats. And we also reviewed project reports and documents that had accumulated over the space of the 15 years. So our results. We provided almost 900,000 clients in 19 countries with abortion care in the time period from 2008 to 2021 in 19 countries. And I'll name the 19 countries because that's a frequent question. Bangladesh, Benin, Burkina Faso, Cameroon, Cote d'Ivoire, DRC, Ethiopia, Ghana, Guinea, India, Indonesia, Kenya, Mauritania, Nepal, Pakistan, Palestine, Sudan, Togo, and Uganda. The majority of the clients that we provided with abortion during this time period, 40% of them received a surgical abortion. About 300,000 received a medical abortion, and about 200,000 of them had treatment for incomplete abortion. And we did note rapid growth in clients that chose to have a medical abortion over time. So by 2016, we noted that medical abortion was actually the more common method chosen by our clients. And I think we see really interesting results when we look over a time span. And this is data from 5 of our member associations that had comparable data over this time period. This is from 2012 to 2021. And what we see is that over these 10 consecutive years, that we have just a huge increase in the abortion clients that were served. And I think the point that we would like to make with this slide is that it takes time to develop a program that matures and that reaches the people that need it. And if you look at 2012, when the programs were quite new, but up and running and fulfilling all of their data collection, and they'd done their training and they had everything they needed, we served about 15,000 clients. And if you look 6 years later to 2017, we were reaching almost 50,000. And over this 10-year time span, we continued each year to reach more and more clients. And this just shows that it takes time and that the need is still there and even growing as a program becomes trusted and known. We noted a number of things from our qualitative interviews about strategies that are central to scale up abortion services. This included investment in clinic infrastructure, equipment and commodities, that the technical training of providers really needed to be coupled with values clarification and attitude transformation exercises to really meet the needs of our providers and staff. that community-level activities needed to provide information for abortion care and facilitate client referral in services. People needed to know the services were there. Also, elements of the program design that we noted that were key to success included flexibility of activities and funding to be able to respond in each country and in each setting to individual needs. That comprehensiveness of activities needed to address both supply and demand side factors. That integration of data collection really needed to happen into data that was already being collected by the facilities, and that it was key to have local ownership and leadership locally by each of our member associations. So in sum, we see that to achieve significant changes in abortion services, it really takes time, and you need to address the following in your programs. Addressing multiple aspects of both supply and demand factors in abortion care, having access to long-term funding. As you remember that slide, over 10 years, it really is a long-term investment to ensure meaningful and sustainable change. It needs to be designed and led by national organizations, providing flexibility to respond to challenges happening in the country that are individual, and including investment in the collection and use of data, and data that the program itself can respond to. And with that, I'll just say the investment in civil society really can impact abortion access at national levels through the sharing of capacity with private and public providers, and can influence the national policies and guidelines in the places in which we work. Thank you.
Thank you so much, Natalie. That was very clear. Do you know how to switch back to the other presenters that are there? Now we're going to do an experiment. We love experiments, don't we? And we said that there wasn't any translation, but the facilitators at the back have said that if you, we'll see if it works, if you scan that QR code, you should be able to get translation from French to English, which will be really important for the next two presentations. And since you've probably all been sitting for a bit, you can get up and move and get closer if you need to. Okay, I'll give you a chance to do that. Okay, so our next presenter is Fiacre Bazi. Hopefully I got that right. And he's going to present for us on the decision-making on how women navigate abortion decisions in Burkina Faso, and the role of their partners, if they have partners, in that process. Fiacre is a PhD candidate in demography at the Institut Supérieur des Sciences de la Population at the University of Joseph Key Zerbo in Ouagadougou. And he has been working as a research officer at ICFP since 2014 on various research projects. And his research really focuses on SRH, our family planning, abortion, quality services, youth, and adolescent health. So Fiacre, the floor is yours.
Okay, thank you, Malaya.
We've heard that there's a little bit of a lag, so you're probably still hearing me, but hopefully it'll catch.
Okay, sorry for our presentation. What will be in French, but the presentation is in English. Et je m'excuse d'avance, la présentation sera faite en français.
Sorry, the presentation will actually be done in French. To come back on the context of the background of this study and this about abortion in the context of Burkina Faso, it's a context that is legislated against abortion, so that is very complex to have a legal support. That doesn't mean that there is no abortion. We do have abortions in Burkina Faso, but they're very serious consequences with methods that are highly not recommendable, and people that actually are doing those services that are not professional. In the end, the abortions are very risky. The idea here that we have done is a quantitative study to see the presence of abortion in Burkina Faso, and it's a qualitative study of the women that have actually agreed to participate in the study and have actually shared their experience with abortion. In the end, we have reached and managed to gather something like 40 women that didn't actually have the proper care after the abortion. So the objective of the study, what we can do, is that the global idea was to know whether there was a difference between the women profile in the decision making, difference in terms of social profile, economic status, in order to be able to access the proper treatments and the proper support. Globally, the women that have participated in the end were 25 women that have actually accepted to participate in the study. So we've done a sample with these women, and we have focused on two aspects. One, where the pregnancy actually happened, the circumstances of the pregnancy, and the social and economical conditions of the family, and the role of the partner, and what was the role of the partner and of the family of the partner in the decision making of the abortion or of the pregnancy first. That's what we focused in this study. So what we have been able to see is the conditions of the abortion at the time of the abortion, the socioeconomic background, the reason for the abortion, the partner and the family interactions, and the social network of the woman. Everything that has to do with facilitating the access to proper care and the access to proper methods of abortion. And the aspects of her abortion experience, especially when we know that the access to proper information and sources of care are difficult to obtain. And the complications, what were the complications and the treatment that she actually went through. This has driven us to get a certain conclusion and similarities and differences in the conditions of the underlying abortion decisions, and we can see and observe three types of dimensions of abortion pathways. that constitute the, 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 the process of decision making and the care seeking. So the context of pregnancy is the first one, the abortion decision making, and then the care seeking. Is the decision actually has relied only on the woman, on the wife, or has the family been involved? And the third point is the care seeking. Where did she find the information? What are the sources of information? And who gives the financial support for this decision? The type 1 is actually teenagers group that have taken the decision to abort. They are between 15 and 19 years old. They are either students or they were in the educating system. They have an easy access to information, which is positive. And they have a little sexual experience. Very often the cause of the decision is because they fear their stigmatization. And they fear to be excluded from their family and from their group. That's the main problem that they're facing. This is a quote from a teenager that says, "I was scared." So in terms of care seeking, these teenagers knew about sources and methods of abortions, either through their partner or through some close friends or family members. So they know how to access the proper care. The second type is a woman that is between 20 and 33 years old. She had at least one young child at the time of the abortion. The decision is more joint with her partner, because the two children are very, very close in age. So that's the decision, why they take the decision. And then they can both look for the proper care. And the third type is single mothers, which are between 21 and 42 years old. The decision of abortion is due to stigmatization again, and it's only the mothers that take that decision, obviously, because she's single mother and she doesn't have necessarily the support of her family. This is the summary of the three types of women that we have talked about, with their socio-demographic background, context of pregnancy, etc. So, conclusion, when we look at the normative expectations, there is a number of people that in the pregnancy stage and in the decision making of abortion is restrained to a certain social and legal environment. Sometimes they have done the abortion in secret or in conditions that are very not recommendable. So we need to investigate the methods that they have actually used for abortion. Most of the women in Burkina Faso think that sometimes they take the decision on their own, or sometimes they take it with their partner, and the important part is what source of information to use and what care to actually use. That's where the educating part is very important, and to support them in the decision making of where to get the proper information and who to choose in terms of care. Thank you very much. I think we'll stop here because I think my time is over. Merci.
Through the presentation or through the QR code. So for the third presentation, we're moving to the DRC, but with lessons for many other countries, I think you'll see as you work through the presentation. And it's really important insights into the role of actors, motivated actors, who are affecting policy change, specifically related to the introduction of the Maputo Protocol in DRC. And it's presented by Ramatu Wadrego. And Ramatu, I hope I got your name right. I practiced for days. She said the OU is like a W. And then all of a sudden it was like magic. Wadrego, of course, you know. But I think she's a little bit Latin American when I pronounce it. Ramatu is a social and cultural anthropologist who holds a PhD from the University of Bordeaux. She currently works as an associate research scientist at the African Population and Health Research Center, headquartered in Kenya. And her research focuses on adolescent and young people's sexual and reproductive health. And she explores this through the lens of social norms, reproductive navigation, intimacy, and public health policies. And she has over 10 years' experience working on issues such as abortion, transactional sex, contraceptive use and non-use, sexual and gender-based violence in both Francophone and Anglophone countries in sub-Saharan Africa. Welcome, Ramatu. Hey, a fan club.
Thanks so much. I'm pleased to be here and make this presentation on behalf of Tess McLeod. She was initially supposed to make it, but she couldn't make it, so I'm doing it on her behalf. And it's a case study we did in DRC in collaboration with another colleague that I wanted to acknowledge, which is Françoise Mukuku. So I think given the time, I will try to go faster. So this is the background for DRC. It's one of the largest country with a great population and rapidly growing, and also high fertility rates. And what is key is that in 2018, DRC became the first Francophone country in sub-Saharan Africa, let me say that, to implement the change to domesticate the Maputo Protocol to improve access to safe abortion services. And with the population that country has, it was really the most populous, a great achievement in making the policy change to improve the access to safe abortion in this part of the world. So we did a case study which was aimed to document the process of that domestication and to identify the different we know that Benin is following, and we will hope also to document that process to inform in other countries. So we did the analysis using the Schiffman framework, which he identified 9 factors grouped into 3 categories. leading to political change, and you can see them here. We have the mechanisms made by international organizations through promotion of norms, provision of resources, advocacy by national actors, and the third one is the national political environment. I think you can go through it later if for those interested. And in terms of methodology, what we did was to review, first of all, documents, including the policies, the laws, and reports from various organizations and also the ministries in the country. And then we did 10 key informant interviews, mainly with actors who were at the forefront of this policy change in the country, using a sort of snowballing also to identify the key ones. And then the last stage was to hold a workshop, a forum, which was, we said virtual here, but it was hybrid, where the actors were able to identify the preliminary findings we found and intend us like to validate it and also add new insight that we did not capture in the key informant interview. So here so in terms of result, here you can see the different timelines in the DRC process. And so in 2018, it was the ratification. And then about my mathematics is very bad. That's why I went to, so in 2013-14, there were new evidence in the country showing the high mortality rates and the link with the issue of unsafe abortion. And then in 2015, there was a reproductive health law that was put in place, but abortion, there was an attempt to include abortion and it was withdrawn. And in 2018, hallelujah, the Maputo Protocol was gazetted. And then in 2020, it was followed by guidelines. So this was done thanks to key factors and actors in the country. And as you can see in terms of norm promotion, we can see that in TUES there was a wide recognition of the role of unsafe abortion in the country. And also in terms of resource mobilization, we have different organizations and foundations that played a key role in bringing resources, when I say resources, financially, but also in terms of technical supports to be able to put things together. And then at the national level, there were key movements. So the actors, instead of working in silos as it used to be, we found a shift with the creation of the group coalition, the grossesse non désirée, which played a key role in that. With I think, and then we have also the focus on key events like the Safe Abortion Day, whereby there was a great movement to display the role of the unsafe abortion in the high mortality rate. And also the generation of evidence to support the advocacy in the country with most related to the unsafe abortion and how it play in the mortality, and also other things. Let me go faster. And then at the political level, there was also some transition with a new Secretary General, new General Secretary that was in place, and which was supportive to the domestication of the Maputo Protocol, and also the shift from seeing abortion as non-essential services from seeing it as a key services. I'm almost through. So the major factors, as I was saying, that contributed to the change in the country were among the cohesion, as I was saying, the creation of that coalition that really put all the actors together to work as one team to be able to speak the same voice and share the same message. And then the other one was about the production of credible evidence, because when you go to the policymakers, what usually lack is those evidence, but when you have them, you can speak. It's not like you are creating something, it's coming from a true picture of what is happening in the country. And then we have also the government ownership in the country, and the other one was also the removing of the barrier for the access, which was pushed mainly. I'm trying to go fast. And then, so in terms of conclusion, we can say that it has a potential template for other countries to really follow the domestication of, implement the domestication of the Maputo Protocol. And it illustrates how the factors can contribute to clarify the legal pathways, highlight the evidence, and also build a political will and streamline policy actors for an enabling environment. So by following that space, because the countries are also specific, but using it as a starting point can also lead to great changes in those countries we are working on. So thank you. I will end there.
You actually have 1.5 minutes left. So if you'd like to expand on your conclusions, please feel free to do so. Okay, we'll save it for the discussion and we'll make sure you get a little bit of extra time because I think your conclusions are very interesting. Okay. I think people panic when they see the 4-minute mark and they panic and it becomes like a bit of a train after that. But we'll have some time afterwards. For those of you who still have the French to English translation, our next presenter will be speaking in French, but the slides will be in English. And Cyprien Masaka Lopepo is working for IRC, and he's really also speaking to the DRC context and how the opening of the Maputo Protocol brought real opportunities to reduce harm from unsafe abortions in conflict-affected Eastern DRC, and some interesting case around the integration of facility and self-managed access to abortion. So Cyprien is a clinical doctor with 7 years experience of hospital services. He has a master's in public health focusing on women and children's health, and he has been with the International Rescue Committee since 2010 in sexual and reproductive health in humanitarian settings, particularly in armed conflict, Ebola, the COVID-19 pandemic context in DRC. He's currently deployed to Central African Republic as a health and nutrition coordinator, and he's contributed to this topic on safe abortion care in numerous global fora. So Cyprien, the floor is yours. I would like his fan club too. Come on, no bias for Rama too.
Je m'excuse aussi, je veux parler en français.
I apologize. I want to speak in French, and since we already have assistance, which enables us to have a simultaneous translation, it is going to make life a lot easier for us. I am pretty happy to talk after my colleague because she really set the stage and she said everything that was done as effort, as endeavors, and as conclusions. She is requesting to follow the example of DRC on as part of promoting a safe abortion. And we have been the actors during that period with a project focused on comprehensive abortion care. And at the end of the project, we were able to analyze the results and complement them with some interviews of the key actors and stakeholders to give us ideas of how we can move forward to reduce the risk related to unsafe abortion, especially in conflict areas like the DRC and especially the eastern part of the country. I think that I will invite you to look at this young girl. She looks a bit sad, right? And obvious she is sad because the figures which are there can get somebody to cry. These figures of things that can be avoided. We've been expecting them since yesterday at the opening, but we can say that if we have around 25 million unsafe abortions and that 8 and 13% lead to death, we think that in conflict countries the figures are higher. However, the worst is that we don't have enough data to show how we can document an approach to reduce these figures. In conflict countries where access to abortion is limited, we don't have figures and we have worked in those contexts. That is why I want to share these results with you. So my colleague said that DRC, with this context and the population had a specificity, that is, they have many crises which are going on till now. Armed conflict in the eastern part of the country. We have people who are running away, and a few months ago we had the 12th or 13th epidemic of Ebola, uh, in addition to COVID-19, which is continuing in the country. And it is against this backdrop that we have worked and we availed the progress of the Maputo Protocol to try and introduce this a risk reduction approach to enable women themselves to be able to self-manage their safe abortion. So I was saying that we take up advantage of the Maputo Protocol to ensure, to guarantee comprehensive abortion in health centers in 29 health facilities in 4 provinces: Tanganyika, uh, North Kivu, South Kivu, and Tanganyika provinces. And this progress helped us to strengthen the capacities of the clinical providers, clarifying what are the laws in place. And also the Maputo Protocol, we train them, and if there were progress on the Maputo Protocol, there was still resistance and reluctance to provide health care. But we train the service providers to give those services. But if they cannot do that, they can tell the woman she can miss protocol, make sure she can manage her abortion and post-abortion care and come back for post-abortion care, which are given to everybody. And we had to clarify values to see how to transform attitudes, be it from providers, community relays, and even some authorities. One innovation which was introduced in the health facilities in those contexts, those facilities are not always used. The population goes to the pharmacy where they can buy medication. So pharmacies are mainly or more used than health facilities. So we were able to create partnership with some pharmacies where we could avail misoprostol, and we trained the pharmacist in providing counseling on how to use the misoprostol, on how to take the doses, and even to take the women that when they take the misoprostol at home, that if they face any complication, they can come back. So with these pharmacies, we entered into a partnership and we availed them with misoprostol. And obviously in the community, we trained the community relays not to carry out massive awareness campaigns, but it was mouth to ear awareness. So we took our data since January 2019 to November 2020. We interviewed 9 key of informants like the Ministry of Public Health, community health workers, the pharmacists, which were in partnership with IRC, and here are the results. Since February was the preparation and implementation of the program. From the month of March, some facilities were already providing counseling and prescribing misoprostol. In blue, we have women who receive counseling at the pharmacy who took misoprostol and who were able to self-manage their abortion in their houses. Total, we had about 4,388 women who took the misoprostol, mainly in pharmacies and health facilities. And among these women who used the safe abortion services, 78% came back because in counseling, be it with the pharmacists or the providers, they were told it is good that after your abortion you take a contraception because unwanted pregnancy leads you to abortion, and 78% came back to take contraception method. So the lesson we learned from this is that the risk reduction approach with counseling for the providers which still have was still reluctant to provide safe abortion services by orientating women, we were able to meet quite a number of needs on this theme, and you have seen how much demand was met, and we also saw that with the collaboration with the pharmacists who were the private partners and the health facilities, there was the community was prepared. You saw the image at the beginning where the girl was sad. You see that with this approach, smile is coming back on our face, and it shows that it can be done. This program can be carried out, integrating this safe abortion approach, working together with health facilities and the pharmacies which are supporting these women who want to carry out their abortion in their houses. And we said that it was during the COVID pandemic. Movement were restricted. The woman at her house could self-manage her case, and it enabled our service to continue. But I think that more research should be done to understand abortion self-care, and to get more ideas to improve the mother and the girl health. Thank you very much.
Thank you very much, Cyprian. So I hope you're getting your questions generated, your discussion points. We have the final presentation of the day is from Irene de Vries. And it's fittingly, I think, looking at the role of healthcare providers in expanding the legal grounds for abortions in 3 countries. And I think it nicely fits with Ramatu's presentation and Cyprian's presentation that we just heard. Irene is a global health physician and with a special focus on maternal and child health, and a social scientist with a master's degree in medical anthropology and sociology. And after working as a medical doctor in the Netherlands, the Caribbean, and Zambia, she currently works as a health advisor for the SRHR team of KIT, the Royal Tropical Institute in Amsterdam. Coming from the medical field with a strong heart for public health, rights, and social change, her interest is in what health professionals can do to bring about change, and that's been guiding her work. The study that's presented here was conducted in 2021 about the role of healthcare providers in Argentina, Ireland, and South Korea. In the past years, Irene has also led the needs assessment, monitoring, evaluation, learning of a large-scale 10-country project in collaboration with FIGO that aimed to strengthen societies of OBGYN in safe abortion advocacy. I think many people in this room would realize the necessity of that. And in order to ensure that she has absolutely no free time in her life, she is also the deputy director at the Training Institute for Global Health and Tropical Medicine, and trains postgraduate doctors in the field of global health. Welcome, Irene.
Thank you very much, Malaya, and welcome everyone. Thanks for joining this session. I am curious who we have in the room, so I wanted to know who identifies themselves as a health provider. Okay, we have quite some. And who identifies as an advocate? More? More than that? Okay, so let's see how we meet each other here in this topic. So let me start a bit with why kids conducted this study. Abortion laws and regulations are key in creating an enabling environment that facilitate the advancement of people's sexual reproductive health and rights and well-being. Notwithstanding the recent retrogressions on abortion laws in various parts of the world, legal frameworks regulating access to safe abortion have also been progressively liberalized around the world in the last century, and that was already mentioned by adding new grounds allowing abortion. The road towards expansion of legal abortion is a long, highly sensitive and difficult process. While healthcare providers have been recognized as key health advocates, their specific role in influencing abortion law reforms has been scarcely studied. Limited insights into the potential role of healthcare providers in expanding legal abortion can hinder effective mobilization of these key players in the field and how their contribution can synergize with efforts of other SRHR advocates. I would like to start with a quote from one of our study participants from Argentina that illustrates the synergies that we require in our ambition for change. It seems to me that going hand in hand, those of us who have an activist role and those who provide services, we are finding a place. I believe that activism alone is not enough, and neither are healthcare professionals alone. I think that the synergy of both is what led to the result. So, with the objective to better understand and identify what can be the role of healthcare professionals and organizations in national initiative aiming to expand the grounds for legal abortion, KIT initiated a qualitative multi-method study exploring the experience of healthcare professionals in abortion law reforms. Ultimately, the study looked at what advocacy efforts healthcare professionals and organizations participated in and how, and what the perceived impact of these were. So what went well, what worked, and what did not. The study focused on 3 case study countries that between 2018 and 2021 liberalized their legal and regulatory abortion frameworks: Ireland, South Korea, and Argentina. The study was supported by a technical working group that included experts on safe abortion advocacy from the different fields with in-depth knowledge on the 3 selected countries. These included academics, representatives of medical societies, healthcare providers organizations, and women's organizations. Through a systematic literature review, we identified 12 articles that specifically described the efforts of healthcare providers in expanding legal abortion. The articles described their contribution in Chile, Argentina, Ghana, Ethiopia, Uruguay, and Colombia. In the 3 case study countries, a desk review and key informant interviews were conducted, 12 interviews in each country, with general practitioners, midwives, nurses, obstetrician gynecologists, pharmacists, CSOs, and activists. The key informants were intentionally selected by the technical working group based on their individual role and engagements or their representation of a key organization. Data was first analyzed separately as illustrative case studies, and subsequently a non-comparative cross-country analysis was done for an overarching interpretation of the main results. So we found that engagements of healthcare professionals was often at an individual rather than at an institutional level. Traditional medical societies were more often at the back, not daring to take position due to the wide diversity of views among their membership, while the advocacy efforts were more driven by individual known healthcare professionals with leading voices in their country, particularly on abortion and with an interest in human rights and public health. Often these healthcare professionals were linked up in alternative healthcare professional networks, such as Global Doctors for Choice in Ireland, Red de Profesionales de la Salud para el Derecho a Decidir in Argentina, and the Association of Physicians for Humanism in South Korea. We also saw that in the different contexts, different type of individual healthcare professionals engaged, depending on the country context and the roles that they played in relation to abortion and the health system infrastructure. In Argentina and Ireland, there was a larger engagement of general doctors. In South Korea, individual gynecologists played a role, but also professionals like pharmacists contributed by providing expert advice on the use of mifegyne to authorities. And reasons for healthcare professionals to engage linked very much to their medical experiences, the first-hand experience with abortion complications and stories of why women need an abortion. They were also pulled by existing movements that wanted to bring in the healthcare professionals' voice. Facilitating factors for engagement included when healthcare professionals were already engaged in these type of alternative networks and when they received support from their direct environments. Also, previous experience as health advocates had a facilitating role. But obviously there were also barriers. These included that healthcare professionals feel a distance to political discourses or feminist movements. They identify more with the technical and medical roles, such as the provision of services or building capacity to other healthcare providers. Also, there's fear of stigma and, thank you, negative reactions, and furthermore, time restraints and economic interest. So, for example, in South Korea, the financial incentives for an abortion result in a lingering discussion whether abortion services should be covered in the insurance system and can be identified as essential medical service. In the Korean context, physicians are mostly self-employed and need to protect their businesses. So some of these barriers are illustrated in the following quote. There's no concept of public health care in medical school. Several dimensions are intertwined. The Korean education system, the difficult process of becoming a doctor, and the right to survive after becoming a doctor are all connected. It's hard to solve one thing. Yes. The roles of healthcare professionals in efforts to expand legal abortion was multifaceted. They engaged in advocacy work, participated in public debates, engaged in knowledge generation and sharing of scientific evidence, built partnerships, and finally they facilitated contacts and entry points with governmental bodies, such as the Ministry of Health. And while the exact form of engagement differed greatly, when healthcare providers took a prominent role, their support was seen as essential, critical, and highly valuable, as their professional credibility contributed to legitimize safe abortion as a public health matter. So in terms of that perceived contribution, it was mentioned that healthcare providers did influence public and legal debates. For example, in Ireland, healthcare professionals were invited to speak on national television programs, radio shows, the Citizens' Assembly, and government debates. In Argentina, professionals also released public statements, and some deputies made reference to the testimonies of healthcare providers spread through the campaign in the National Congress. In South Korea, healthcare professionals contributed to localizing the conversation on abortion. And that's illustrated by the left upper quote that compared a previous unsuccessful ruling with the current successful one. There were a few medical professionals who participated then during the ruling of 2012, but it was limited to bringing out global cases and the global legal system. However, in 2016, more medical personnel cooperated and the frame leading the discussion changed. So she was referring to how by then professionals were more able to contextualize the case to the Korean context. Another contribution that they made was that they filled gaps in abortion narratives. They were able to illustrate narratives to show that all kinds of people need an abortion. And they could provide evidence to show that decriminalization does not increase the total number of abortions, but rather reduces unsafe abortion. The right upper quote gives another example of a contribution. The discussion concentrated on specific clinical experiences, professional medical knowledge, and medical information, such as clinical results on the use of pills to abortion. This helped the activists to respond to the issue with more medical basis. Furthermore, they amplified women's experiences through testimonies and providing evidence. And I will go a bit faster now. Finally, they mobilized fellow healthcare professionals and the public. So for example, in all contexts, thousands of healthcare providers signed a declaration, and by speaking out in public, they leveraged their trustworthy voice. Key takeaways. Healthcare professionals can be effective key players in national abortion movements. It's important to recognize and support the diverse roles that they can have, and necessary to create a supportive environment for operation. It's important also to equip healthcare professionals with skills beyond the medical expert role, and to facilitate strategic partnerships that seek complementarity between multiple stakeholders. Thank you for listening. This slide shows a few more contributions for this study. And if you want more information on our work, you can check the website also with more information on the work we have done with OBGYN societies. Thank you.
We have about 10 minutes for discussion, so I'll ask all the presenters to come up front. Little guys, the presenters get chocolates from Switzerland because they presented. If you present, you will also get chocolates. The way the stage is set up is a little bit unfortunate, and now I know why the previous one had the chairs in the front. Yeah, why don't we just pull? Okay. Yeah, it now makes sense, right? I'll take your chocolates. So So yeah, just move these chairs up front. It's very divorced from, we need to feel close. I think what's striking, of course, I have hundreds of questions, but the floor is really yours. But I will say one comment that struck me is in the work that I do, or we do, we often hear about healthcare providers refusing to provide care or being biased in the provision of care. And I think quite a lot of the presentations in these particular contexts actually talked about and spoke about how we can work with healthcare providers. Now we're going to have a mic issue, I think. So I'm going to take a couple of questions. I don't know if you can either shout or go to the roving mic. Who has some questions to start with? I'll take 2 or 3 and try and clump them.
Oh, is it working? Oh,
Yep.
Hi, my name is Michaela. I'm a doctor from Poland. Let me wear that hat today. I have a question with regards to the last study, because I'm literally, my head is already fuming because we want to do exactly the same thing in Poland. But I was wondering if you had any component with regards to self-managed abortion and what the doctors think about self-managed abortion, if you can kindly expand if there was anything that you found particularly interesting for the links between healthcare providers and the self-managed abortion. Thank you.
Okay, there. Can we get a couple questions and then, because I think there'll be some links. And just introduce yourself, where you're from, whether you're an advocate or a service provider.
Hi, my name is Chioma Ndivisi. I'm from University of Pennsylvania in the U.S., and I would say I'm both. My question is, again, about self-managed abortion. I would like to hear more about the role of community workers with trying to find women that had incomplete abortions or to help assess care. Not so much the role of the healthcare provider, but how the community used its resources and community health workers in that, if possible.
And I don't know if we have somebody who's more bilingual than I am to help translate that last question. Just so, because I think Cyprian.
Excuse me, can I just, if she could ask the question, say it again, so that.
It's about the role of community in self-managed abortion.
Yeah, something related.
Yeah, if we just translate that one before you come in, because otherwise we'll get a bit lost.
Donc la question c'est par rapport au rôle de la communauté dans la.
Do with the community in terms of what we call self-abortion, and if it contributes to health consequences.
Thanks to the presentation from all of you. And I'm Nandini, I'm from Asia Safe Abortion Partnership. We work very closely with service providers and activists, and we look at the two as intersections. My question is actually on self-managed abortions, because I'll be speaking on it in for something around that FOSS Feminista is co-organizing a side event. That are we looking at self-managed abortions as something which where women and girls are given the information, given the, the access to the pills and all of that. But what about the health infrastructure and the accountability? And so, instead of looking at it as another sort of service delivery thing, but where is the rights-based approach to this conversation? That is my question on this.
Thank you very much for the questions. If we start with the question on the context of Poland and how applicable this is,
Yeah, thanks you very much for the question. And hard times in Poland. So our study did not look necessarily at self-managed abortion. It looked at legal reforms. But from my experience, I think that the main barrier there is the in familiarity of healthcare providers with self-managed abortion, and also the perception that abortion is something that still needs to be medically guided. So in that sense, I think there is a role for medical providers and especially also associations. And I think that some of the global leading organizations such as WHO and FIGO are already stepping up on that in presenting that there is sufficient evidence that self-managed abortions are safe and possible. And that evidence, and translating that type of evidence to population and to the larger public, I think that's a role of healthcare professionals as well. So I hope that answers your question, and probably others also.
Yeah, just to add to that is that self-managed abortion doesn't mean that there's no role for providers. And I think it's very important that providers step up to be supportive for women who choose to have self-managed abortions. Sometimes people need extra help. Sometimes people change their mind, and there's a role for providers along the every step of the way to support women who choose to have self-managed abortions.
Oui, évidemment,
Of course, the community has a big role to play in terms of self-management abortion, because as we have said, the community and the community members are implicated in this approach in terms of awareness, sensitization. There are people in the community that are that have a big influence, and very often the women tend to actually confide in them. So that's the first role that they play. And the second role is also to facilitate a reference, a proper reference towards the health system. And that answers the second question. Of course, this has been, first it starts in the community, but after that, the role of the health center has a big importance, and they are putting into place, they are implementing proper services from the public center and the public system to actually take its role. And they have to create the proper expectations so that the women come back to them if they have any problem.
That at the community level, there are community health workers who play the role of providing the information, like they are, providing the information to women. And also in case of complication, they are there also to refer them to the health system. So it's saying that it brings the role of the health system in that. So they are accessing the services, but in case of complication, they will be referred to the health facilities for the providers to take care of them. And the providers also play a role in also sharing those information about the self-managed abortion and the safety around it.
We started a few minutes late, so I'm going to sneak in a couple. We have time for 2 more questions. I'd like it to be off the topic of self-managed abortion, so on another theme, because I think you can follow up with the presenters in detail if you want to talk, but on another theme related to the policy or healthcare professionals or long-term investments, etc. My friend.
Good evening. My question goes to the second presenter on the law. She mentioned about the role of providers in the provision of abortion services. And from the ground experience, especially in countries where abortion law is somehow restrictive, there should be some factors that really determine why providers are ready to provide services. So could we at least brief us about what are those factors? the comfortability for them to offer the services. Thank you.
I was, good afternoon. My name is Arnob Chakraborty. I'm from Red Orange, based in Netherlands and Bangladesh. My question is, to what extent do you see the role of drug sellers when it comes to MRM? Maybe you would like to say anything about it. Pharmacists, and
focus of his presentation. And Maifu, did you have a question? We're cheating a bit. But he's at
Yes,
the mic.
of course. I know. I just have one question. Just to know if you have some shareable experiences on management of opposition. Thank you.
Great. And on that management of opposition, I think you all have experience, but I remember, Irena, I think it was speaking with you that how you manage the opposition depends where the country is, because the opposition takes different forms depending where you are in the legal and policy environment. Why don't I'd just like to go down the row for last words, and then you can address the questions as you go down the row.
Je réponds aux questions. J'ai fait quoi? La question n'a pas été.
Which question? Okay. Okay. It's true that the situation in RDC, DRC, has to do with the implementing of the measures and the conditions of the access conditions to the possibilities of abortion. It has to do with the context of Burkina Faso, where the legality is against it. So what is actually recommended when people want to take that type of decisions? What are the recommended methods? It is just what I wanted to highlight. Even if we are not at the same progress level, we can always exchange experiences. I will take advantage to answer on the role of pharmaceuticals, especially in this program of self-abortion. Of course, there is an evaluation that has been done, and they have been trained actually on those products and on those circumstances, and they've also been trained because some women only attend the pharmacy. So that's when the pharmaceutical can actually answer. And they can advise her on what she should take and what she should do, or could give a proper recommendation. But the health ministry has actually been training the pharmacies and the pharmacies personnel for those conditions. Sorry, no translation is possible without the micro. One more minute.
So a quick one. I was recently on a safe abortion dialogue in Côte d'Ivoire in the Francophone region. And what came out in terms of opposition was the lesson from other countries was to do a recurrent mapping of those opposition, and like even put in place in those coalition as a monitoring team that will be following them in the long term to be able to design strategies, to be able to address whatever they come up with, because they are, as you said, they take various forms. And some people were saying that it's actually people they knew with who they share experiences, the work they are doing, and then they will later on find out that whatever they share with them is used against them. So it requires a consistent monitoring to be able to identify them, and then build also champions within the community and within the health system, and also at the political level. They share different type of actors they use as champion to be able to help address this opposition, because they can play in preventing policy change, as we are seeing in various countries. But even in countries where we are able to reach a policy change, like in DRC and in Benin, they still play a role in preventing like the implementation of those new policies, and also the access to the services through ground movement in the community, but also among the providers who will end up not providing those services. So that's what I wanted to add.
Thanks, and I let Ramatu go on because she cut her presentation. Do you have things to mention that Ramatu hasn't mentioned in terms of?
Yeah, maybe just very quickly, and then I pass it on. Big topics indeed. Some of the barriers that we found were that many health providers are unaware of the legal frameworks that they operate within, and not able to separate their personal beliefs from their professional obligations. And I think that is where VCAT, you've also referred to it, plays a huge role. And what we saw a lot in the work that we've done with FIGO is that, of course, medical societies, they do have a huge potential in driving change, but they really need to overcome their internal barriers and struggles first. And that is a long process as well, but also VCAT there played a big role in the work we have done so far, but still long way to go.